Okay, so we talked about what is good alignment. I need to fix these slides. I totally went out of order. Next time I'm gonna fix it. But now we know what good alignment is, right? Okay. All right, so what do you guys notice here? Her neck. Yes, and look, she looks like she's like she's straining, right? This is no bueno for her pelvic floor. What do you guys see here?
Well, the first one.
Not bad here, not too bad, right? But what happens when she moves? Exactly. She's got like that scissored. Yup. Okay. And then what do you guys see here?
She's like,
Like, how you doing, right? You know, like, no, we gotta relax the tailbone, okay? And what do you guys see here?
Her shoulders are back.
A little bit, yeah.
this one's more subtle.
It's more subtle, yep.
Her knee is not stacked.
Yeah, no, her knee is pretty good. Her
But
rib
the-
cage. Her
the
rib
rib
cage
cage.
is a little bit tilted,
Correct.
okay? You see her sternum here, okay? Shoulder's not too bad. Her neck is good, I'm happy with her neck. And then here, what do you guys see?
Going forward.
What's going on forward?
The knee is.
A little bit, yeah, a little bit, right? We don't wanna be here, we wanna be more here. We do wanna be more singing to the body a little bit, depends on what we're trying to target. But again, her rib cage.
Yeah, it's forward.
Everyone always sticks out the chest to get the shoulders back,
Yeah.
right? So even though you're working on this, it's influencing this, the pelvic floor. All right, we did the dowels, we did a little bit of dowels. You saw how we had the dowel behind you. We want everything to be touching the dowel, the tailbone, the mid-back, the head. Okay, that's how we kind of can get feedback and practice what is stacked alignment. All right, so we're gonna debunk some myths and facts. Dr. Lauren's gonna take over.
All right, I'm up. And it's just like the phone.
Yeah, just enter. Okay.
Okay, so they're listed, we'll go through them kind of one by one. The first, myth or fact. Pelvic floor problems are a normal part of aging. Anybody in the room feel like that's true?
No.
It's not true, okay? We want to normalize talking about these things, but not normalize the issue themselves. Okay, so, sorry, pelvic floor problems are a normal part of aging. This is a myth. Oh, okay. Oh. All right, sensitive, it gives it a right.
Yeah.
Okay, only women need to think about their pelvic floor. Do we think that's true?
No.
I just learned that recently.
Yeah, right, so anybody who has a pelvis has a pelvic floor. Some of the patients that I treat are actually men. Men can suffer with prostatitis. A lot of times men will come to see me after prostate surgery, right? There's a higher risk of incontinence after prostate surgery. And then constipation is another one, right? So these are some pelvic floor disorders that maybe people are not necessarily associating with their pelvic floor, but can be treated if you're seeing a pelvic PT. Or pelvic therapist, I should say, because there are OTs who also.
Yes.
All right, so Kegels are always the cure for pelvic floor problems. No, okay. That's one of those things that I think, especially when I first started presenting years ago, that everybody heard pelvic floor and automatically would say, oh, Kegels, right? And so we are really trying to move away from the association of Kegels are for everybody because just as Dr. Stella was saying before, right, sometimes it's not just an issue of weakness, right? We need to make sure there's a coordination between your breathing, your pelvic floor. A lot of times the issue isn't weakness, it's tightness, or maybe there's both, right? So you don't want to just be trying to strengthen an area when you're not really sure how it's functioning. Pelvic floor has to have a range of motion, right? It's a little bit different than say like my biceps range of motion, but there is motion there, there has to be, right? The pelvic floor as you breathe should move with your breath. It acts like a trampoline, and if it's not doing that, then that will show up in certain ways, like symptoms like incontinence or pelvic pain, or even that pelvic heaviness or pelvic pressure. Okay. You should stop the flow of urine properly to do a Kegel exercise. Okay, so this is one that I feel like was really common in the old magazines, right? Where, you know, they would talk about Kegels or Kegels, right? Okay, so this is not true, all right? Work to this one, right? Yeah, okay. So there's a complex relationship between the brain and the bladder, and they're always talking to each other, and that's kind of how you know when, ooh, I feel that first urge, or you know what, I'm in a meeting, I can hold off and I can wait, okay? Thing is, when you go into the bathroom, you're making a conscious decision, I'm going to relax my pelvic floor muscles, and my bladder is going to contract to empty, okay? Ideally, when that happens, you're going to empty completely. We don't wanna then do a Kegel because we're closing the pelvic floor, and you're gonna confuse the bladder, because the bladder said, you just told me to empty, right? So you don't wanna confuse that relationship. So anytime you're at the toilet, you should be emptying completely. Now, if you've been instructed to do Kegels, if that is, say, something that you've discussed with your therapist, then you would not wanna do that on the toilet. If anything, you should be working with somebody who's going to teach you these proper techniques in more functional positions, right? A lot of times you'll learn how to isolate the pelvic floor, first laying down on your back, but pretty quickly you're gonna move into more functional positions like sitting and standing, because we don't live our entire lives on our backs. Okay. Let's see, next one. Incontinence can only be treated by medication or undergoing surgery. Do we think that's true? No, if that was true, I'd be out of a job. So a good chunk of people who are suffering with incontinence will do really, really well with conservative management, right? Including pelvic floor physical therapy. So, you know, the fear is, oh my gosh, I'm gonna be on this medication for the rest of my life. Ideally, you'd be able to completely avoid medications altogether. There are certain people who do well with a combination of both medication and physical therapy, but I think most conservative measure usually is to start with physical therapy first. Okay. And then our last one, pelvic rehab can treat a variety of conditions, including pelvic pain, bowel dysfunction, pregnancy, postpartum related pain. Do we think that's a fact or a myth? It is a fact, of course it's a fact, right? And certainly by the end of the presentation, I should have convinced you that. All right, so pelvic rehab, who is it for? Do you have a pelvis? Congratulations, you're an excellent candidate. Okay, so pretty much everybody in this room, and I think everybody on the planet, could really benefit from having their pelvic floor assessed. And the reason behind that is because when we think about all the muscular attachments, right, this is kind of like our home base. Our abdominals connect at the pelvis. Our upper leg muscles, right, the quads, the hamstrings, the inner thighs, the adductors, all of these have pelvic attachments. Your lumbar spine attaches to your pelvis, and then your pelvic floor, right? That bucket, the support system for your pelvic organs, including the bladder, the bowel, the uterus, right? All of these attach to the pelvis. So if we're not paying attention to this very important part of our body, we're probably missing something. And you might be thinking, well, I don't really feel like I have anything wrong with me. Like, do I really need to be assessed? Well, let's start talking about some of the things that are common signs of pelvic floor dysfunction, right? So incontinence is kind of the major one. That's a little bit more obvious. But some of these other ones you might not have ever connected that might be associated with the pelvic floor. So low back pain, tailbone pain, right? If you've ever fallen, gone skiing, rollerblading. Who has rollerblades? I don't know, I still have my rollerblades.
I don't have any more, but I have.
You know, so a tailbone pain, right? Maybe you've fallen and something's always just kind of felt a little bit off after that, right? Like prolonged sitting, you're like, what kind of feel that, right? Again, all those muscles that are attaching at the pelvic floor, they get really tight because now they're in a shortened position over time. There are things that you can do to relax those muscles and relax the tension on the pelvic floor so it's not being yanked in one direction or another. Hip pain, pelvic pain, abdominal pain is another one, right? Abdominal pain can be kind of diffuse in general, but certainly there are other things that are associated with abdominal pain like endometriosis or even like old scars. I don't think scars get enough attention.
I get it for my C-sections on the left side, but sometimes even 20-something years, like I move quick and I'm like,
yeah,
and it's a lot, and it's always on the same side.
welcome. So yeah, scars, I mean, they heal to look like just one thin line, but what's going on underneath? Generally, there's gonna be some scar tissue and it's gonna adhere to whatever's underneath. So if you've ever had an abdominal surgery, right, that's one of the things that we'll look at first is how is that scar moving? Is it adhered to something underneath, right? Because you have a bunch of stuff in there. And that anytime scar tissue gets tight or taut, it will restrict blood flow, it can restrict movement, and so then that can develop into secondary issues like constipation. Pelvic pressure, right? That's another heavy one that I think is not often associated with the pelvic floor, right? But you kind of get like a general feeling of like, oh, this feels kind of pressure down there. It's kind of, it doesn't hurt.
Pressure
right?
out or?
Your pressure down could be forward, like in the lower pubic area, could be underneath. I've had a lot of patients say, oh, like I didn't really even feel anything was weird until I was bathing myself and I was washing that area in the shower and I felt something that felt like it shouldn't be there, right? So you might not necessarily even have pain, but there's other indicators that maybe there's some pelvic floor dysfunction going on. We mentioned constipation. Clinical definition of constipation is less than 3 bowel movements per week. But we actually know that you can be constipated even if you're going every single day, right? Because there's other things factoring in. A lot of times you can have like fecal impaction further up the train, right? And so maybe you're having diarrhea all the time, but actually your main issue is constipation because you've got hard stool and the only thing that can get around that is liquid. Okay, so even diarrhea is sometimes an indicator that there's a pelvic floor dysfunction. Pain during sex, right? That's another big one that a lot of people just kind of, because it's taboo, they don't talk about it, they don't even bring it up with their doctor. But there are things that we can do, especially as a pelvic therapist, to help you to relax the muscles if that's an issue. We talk a lot about patient education, like different lubrications that can be used. And the benefit of seeing a pelvic PT too is because we usually have a lot more time to spend with our patients than the doctors who don't think to mention these things. Okay, bladder leaks, and that goes along with the incontinence, and then urinary urgency.
Question for you. You mentioned endometriosis. I have endometriosis.
You do?
Yes.
Thank you for sharing.
So how can be affected with the pelvic?
Well, so usually like patients who come in and they have a history of endometriosis, right? As a therapist, I'm not treating your endometriosis, but I'm gonna be treating the secondary facts of what's going on. And typically because there is a history of pain or a lot of times painful periods, we can do a lot of visceral mobilization, right? Making sure that things are moving. So again, the blood flow is good, making sure that because there tends to be a history of pain, there's a lot of guarding in the pelvic floor, and so then it gets very tight and short over time, so working on relaxation, and it all goes back to that kind of pressure management situation. Did that answer your question?
Yeah, thank you. No, I'm much better now that I'm going through the older stage of menopause, right?
Yeah, well, we're gonna talk about menopause in a
But
minute too.
in the past, it was, everything that you mentioned was painful. I have very painful periods.
Yeah.
It was just, I can pass out just with the
I
pain.
believe it, right?
With
That's,
the pain, yes. So,
yeah.
thank you.
Oh, of course. So one of the main things that I think we see the most, just because that's what doctors more often will think to send, is patients who are suffering with incontinence. And so it's worth noting that incontinence, you can have a urinary incontinence, you can also have fecal incontinence, right? Different forms of like fecal smearing even, right? Where you're like, oh, I'm not pooping my pants per se, but like I noticed that maybe there's like a little bit of stain in my underwear, right? These are also things that pelvic PT can address. In terms of urinary incontinence, you have your stress urinary incontinence. That's like the laughing, the coughing, the sneezing, I pick up something heavy. This usually indicates, again, that your squeeze pressure of your pelvic floor is being exceeded by the intra-abdominal pressure. Right? So if the pressure gets really high, I hold in my sneeze, but my pelvic floor is weak, I'm gonna leak, okay? Urge incontinence is a little bit more where you have that sudden strong urge to urinate, you don't necessarily get to the toilet in time. This usually means that there is something that's triggering a bladder spasm, and that also the pelvic floor isn't kicking in fast enough. Okay, there are certain things that will contribute to urgency, namely caffeine. Right, so usually we'll go over even diet when we meet with a patient because there might be like little hidden culprits that you're not realizing that are affecting your urinary frequency or your urgency. Caffeine's the big one, chocolate, anything really spicy, right? Anything really acidic. Okay, so like vinegar, everyone says, oh, I had a lovely salad for lunch, and what did you put on it? Oh, I put oil and vinegar. Okay, vinegar is acetic acid. It's acidic. And so that will be a little bit irritating to those linings of the bladder, and then therefore will have you feel more urgency, maybe more frequency. Generally, overflow incontinence we're not treating so much because it usually means there's an obstruction happening. That's usually managed a little bit more medically. And then mixed incontinence really refers to people who have both urge and stress happening, right? And those are the patients that sometimes do better with a medication management and physical therapy, but physical therapy should be first. Alrighty. Okay, so we were talking a little bit about pelvic health through the lifespan. We've kind of established that it's not just a normal part of aging, but I think a lot of people still associate these issues with later in life. But it's important to note that plenty of younger women are experiencing incontinence. Okay, so there was a study done talking about the prevalence of urinary incontinence in young female athletes. That's from the British Journal of Sports Medicine, 2002. The key findings were that up to 28% of young female athletes experience stress incontinence during sports activities. The study highlights that high-impact sports increase intra-abdominal pressure, which can stress the pelvic floor muscles, leading to leakage. Right, so again, that's that issue where their coordination isn't there, and that exertion, that impact, is exceeding the ability for the pelvic floor to fire and to fire with strength and at the right time. Okay, this is treatable. We treat a lot of young female athletes. Moving through the next stage of life, right? Thinking about pelvic floor challenges during pregnancy and postpartum. Urinary incontinence, again, tends to be the one that's most common. It says here nearly 30 to 50% of women report experiencing urinary leakage during pregnancy, which can continue postpartum. We think that might even be underreported, right? Because again, there's still some shame and stigma about this, and so people aren't really necessarily talking about it until it becomes something that's completely affecting their life. Up to 33%, so that's a third of postpartum women, report urinary incontinence 1 year after childbirth. I am really hoping that number starts to go down as doctors more often will send patients, right? And that's, Dr. Stella and I have been advocating for so long, trying to get doctors to do that more automatically, because they don't do that here, and I don't know why. In France, it's standard. You had a baby, you go to pelvic PT. Here, it's like you have to be the one to advocate for it. Pelvic organ prolapse, that's another one. So pelvic organ prolapse is when the abdominal contents or the pelvic contents descend down into the pelvic cavity. So you can have a dropping down of the bladder, you can have a dropping down of the uterus, you can even have a shifting forward of the rectum, and that can create like a constipation issue. And it's
Why did it fall down like that?
Just you start to, either there's a muscular weakness or the other support systems that are there, like your ligaments support, will weaken over time, and then because there's less support, then there's a shifting. And then same thing with the constant, like if there's a high intra-abdominal pressure, like say you're someone who has chronic bronchitis and you're coughing a lot, think about all that downward pressure constantly, and that takes its toll on the pelvic floor. So here it says up to 50% of women will experience some degree of pelvic organ prolapse after childbirth. That's half of all people who deliver a baby. The risk increases with vaginal births, larger babies, and prolonged labor, but these are just risk factors, right? It doesn't mean that these are the things that have to happen in order for you to have some level of pelvic organ prolapse. So, I mean, there's a good chance, a good chunk of us in this room are having this kind of stuff happening, and we might not even realize it's happening until later when the other stuff starts to crop up. Okay, pelvic floor challenges during pregnancy, postpartum continued. All right, so pelvic girdle pain and low back pain tends to be another thing that we really deal with in pregnancy. We have a little model here. It says, as the hormone shifts during pregnancy, the integrity of the joints and the connective tissues are often affected. So usually between weeks 8 to, I think, 15 of pregnancy is when the relaxin hormone is at its highest. Okay, so that means we're gonna have a little bit more movement, a little bit more laxity in our joints during that time frame. It kind of dips down and then it peaks back up towards the end of pregnancy. But especially early in pregnancy, if you're thinking about your bony pelvis, right, you have at the front the pubic symphysis, in the back your two SI joints, and then generally, right, there's very little movement in those areas. But because now during pregnancy you have the relaxin, you're getting a little bit more movement, that also lends to shifting, right? So there's more movement than there should be in those joint areas, and that's a pretty common area where people will experience pain. But there are things that we can do to lessen that. And one of the easiest things, yes, you have a question?
Yeah, I was gonna say, like, I have the really bad, like, pubic symphysis, and it's even, like, 6 months postpartum. Like, it was to the point in pregnancy where I couldn't, like, get off the bed or, like, shift
This
at
is
night
really
without, like,
common.
literally crying in pain.
You gotta come
And-
see us.
Yeah, well, I didn't know if, like, I feel like I have so many of these issues that you're talking about, and I didn't realize, like, they're all, like, related, but,
Absolutely.
even now, like, 6 months postpartum, like, I'm starting to get back into working out again. And if I do like a treadmill for an hour, like I will still have that pain. It's not obviously as severe as when I was pregnant, but it's like crazy how long it can affect you, like even after you've had a baby.
I mean, we certainly want to see a little bit more about what's going on.
Yeah,
for
sure.
certain. And thank you again for sharing that
Yeah,
experience.
no, I didn't know that was like all kind of
It's
related.
all connected. That's it.
I just assumed, okay, side effect.
Just curious, did you tell your healthcare provider that you were having pain when you were pregnant?
Yeah, and they were actually
what'd they tell you?
referring me to a PT.
Oh, they
but-
were?
Yeah.
Oh, good, so it's, they're getting,
It just,
they're getting the note.
Yeah, when you have so
So-
many things going on, yeah.
Because we see a lot of women that come in around 30 weeks or something, and they're like, oh, I've been suffering since 21 weeks. And I'm like, you've been suffering for almost 2.5
Yeah.
months and no one told you to go see someone?
That's
Yeah,
great.
well, I
Yeah.
actually, after my first baby,
That's me.
yeah, you have that too? I
No,
saw.
I just have stress incontinence
Did
already.
you tell your healthcare provider though?
Did I? It's hard to remember anything now.
Oh.
Yeah, I went to a
Yes, I
PT
did.
the
You did?
first
And what'd they say?
pregnancy after.
See, that's what Dr. Laura and I were really trying hard to educate.
Yeah.
And New Jersey just passed a bill, I don't mean to sidetrack you, I'm very passionate, we're very passionate about this.
I know.
New Jersey just passed a bill that is requiring healthcare providers that see pregnant and deliver babies to educate them on this kind of care, and they need to step up.
Yeah.
Yeah.
It's true, right? So on here it says estimated 42% of pregnant individuals experience pelvic girdle pain at 15 weeks. Okay, generally you're going to be pregnant from 38 to 42 weeks, and if your doctor is just saying live with this until then, that's a really long time to be in pain, and so you should know that you have options.
And the girdle pain, does it include like bone, muscle, and, like neurological?
Yeah, I mean, depending on where you're feeling it, right, might not be the source of the pain too. Our body's really good at what's called referred pain, where maybe you're feeling the pain down in the groin, but it's actually coming from up here or even up higher. So that's the benefit too of being evaluated, where we can really get to the source of the pain, right, the root cause, and then treat from there.
I have a random question, is that actual size?
I mean, it's meant to be to scale.
It was tiny.
It's the size for a small woman.
Yeah.
Not 5 foot.
Alright, so the role of pelvic floor therapy in birth preparation. So this is the other thing I think that I'm getting really excited about, because this is newer in the field for pelvic PTs or PTs in general to be able to do this type of work, right? There are studies to show that perineal massage and stretching helps to reduce the perineal tearing for anybody who delivers vaginally, and reduces the risk or need for an episiotomy. So this is really fantastic information, and usually we can spend some time during a session learning how to do that. We can even practice it so that you can feel more comfortable with your body. Some people are a little squeamish about their body, right? So we can kind of coach you and help you to get more comfortable to know how to do that, or even bring a partner in and teach your partner how to do it for you, so you could just chill. Okay. The other thing, biomechanical preparation and optimal fetal positioning, right? So we talked a little bit about the flexibility and the mobility of the pelvis. Well, birth prep also means that if we know that you're planning for vaginal delivery, that positioning makes a huge difference as how the baby can rotate and descend through the pelvis, right? There's an optimal way for the baby to be positioned. A lot of times they kind of get stuck, right? Different stages of labor might require different positioning, and sometimes even the doctors don't think to suggest that. They strap you down, they have you on your back, you're laboring on your back, but movement is going to be really key, right? When the baby's in the top part of the pelvis inlet, we want to favor more positions with outward rotation of the hips, so that makes space in that top part, right? But then later on, as the baby descends, the pelvic inlet, which if you're sitting there and you're in external rotation, right? So now down here, you see how that space gets narrowed. So ideally then during later stages of labor, you're going to favor more internal position or internal rotation, so that makes space for the baby to come through, right? So it's things like that that are kind of simple, but maybe your provider isn't taking the time to go over with you. We can spend that time.
Sorry, I just have one more thing.
Yeah.
Have you ever heard of shoulder dystocia?
Yes.
So my first son had that at delivery, which was like super stressful. It's a benign counter. I just don't know if that can cause maybe some of the long term, maybe that. Because it's like when the baby gets,
brachial plexus?
yeah, like he basically got stuck, and so I had to like rotate him out of the pelvis. So I don't know if that can cause like maybe some longer term effects on your pelvis because of the way that it was like manipulated, or just having a larger baby in general, yeah, I was just wondering if
Yeah.
that could cause some effects on
I mean, certainly, like any labor, whether you're laboring vaginally or you end up delivering via C-section, these are like traumatic experiences to the
Yeah.
body. And, you know, as much as the society is normalized just like bounce back culture, we need more guidance than that. You go to your 6-week follow-up and the doctor's like, great, you're cleared to do everything you were doing before.
God, yeah.
Well, if you don't know what I was doing before, you really shouldn't be telling me that you're cleared to do that, right? And really, all they're really checking at that 6-week appointment is like, is your cervix closed so that there's no risk of infection if you're intimate with your partner, right? But beyond that, like if you were a runner before and they said at 6 weeks you can start running, that's not safe for you yet, right? And especially if you're breastfeeding, right? We didn't even talk about breastfeeding, but the impact of breastfeeding really means that it will take a little bit longer for your hormones to stabilize. And I didn't ask you if you were breastfeeding, but you said, oh, you know, it's 6 months postpartum, but it wouldn't surprise me if you were still having some pelvic girdle pain at 6 months because you weren't given any guidance on how to help that. And then if you're breastfeeding, your hormones are still affecting your ligamentous laxity. How are we doing? I feel like I'm like.
I think we have about like 5 more minutes.
Okay. I don't think I have too much more. Okay, so just to talk a little bit about menopause, perimenopause, maybe that's applying to you, maybe it's not. But estrogen is key, okay, during these 2 stages. Estrogen is crucial for various bodily functions, including the regulation of the menstrual cycle, maintaining bone density, and protecting the cardiovascular system. And especially that last one is super duper important. Perimenopause refers to the time period before the cessation of the period. That can be up to 10 years.
That's insane when they told me that.
I know.
Yes.
You were like,
Even the
Yeah.
even the hot flashes, you can have it, they disappear, but that doesn't mean that you can have it back in 5 years.
That's a whole other con- It's
Especially-
ridiculous.
Yes,
Another
and
conversation.
And then
You said it could
menopause.
be 8 to 10 years, I'm like,
Yes.
excuse me, what?
And we are complaining, but you know, the people who have more in any period of time is the people, the African American population, they're worse. Because if we complain about 10 years, they have it 15 because that's.
at least people talk about it now.
But yes.
because
I love that we're talking.
Yes.
Yes.
It's, I talk about it, people at work, so I'm like, this is ridiculous.
And it's really rough, right, too, because you can have like an 8 or 9 month period where you haven't had a period, right? And then all of a sudden you get
Oh,
a
yeah.
period.
I know.
and
Yeah,
it
yeah.
starts.
I think that happened to my
This
mother, and she
happens.
was so confused. She's like, I
Yeah,
always thought maybe.
yeah, you
Right,
go
but
to
sometimes we
the
had it to the point where like, we thought we were dying, we were bleeding so much. Like, it was like I was being murdered, and luckily someone had told me that they had the same, because people talk about it, I'm like, oh,
Yeah.
thank God, because
You don't feel
like,
alone,
I had like,
yeah.
bought like ultra tampons, and I was still like I was like dying.
Yeah.
See,
So,
normalize
people have to
talking
talk
about it.
But I was like,
Don't
okay,
normalize the
and it
condition.
still sucks, but at least I know I have time to talk to the doctor, I'm not like really dying.
And you're not the only person going through it, so you're
Yeah.
like, okay, I feel a little more normal.
Yeah. It's crazy.
Okay, so we did just a quick review of perimenopause versus menopause. But during these phases, estrogen levels are gradually declining. All right, I have just, I think, a graph here that kind of shows, nice little infographic, kind of, you got your hot,
You didn't put another woman over there. You don't wanna look like the first one.
But yeah, so it's usually between 35 to 45 is where we get
It's
like
long.
the,
Yeah.
I know.
Oh my
Like,
People
we're
have
starting-
sex.
We're starting to get that like
I had
last
my
regular
second son
period.
was almost 37.
Anyway, so that's, you'll get this in the slides too, so
Yes.
yeah, for you. Common symptoms, cycle changes, mood changes, physical changes, vasomotor changes, right? Like, look at, I mean, you can't see it here, but
No blood
dizziness,
cells.
gum problems, like you are dealing with a lot. Okay?
Onset of allergies, and all of a sudden you have
Can't remember
allergies.
anything.
Nothing.
Yeah.
And so a lot of this stuff is things that, as physical therapists, we can also address, but there's also the importance of knowing that you have a hormone that, you know, is controlling a lot of these things that has dipped. There's been a lot of debate about hormone replacement therapy, right? I think now we're really seeing that there is no increased risk of breast cancer.
I started taking estrogen, I started
I
a couple
know
weeks
now
ago.
on the homework.
Yeah, right, so, so that's just in here, just so that you know, right, that estrogen matters, right, there's a whole book on it. Dr. Stella's a big fan, I know.
Yeah.
And so, yeah, just to get back to kind of the importance of exercise, right, because we talked about the estrogen and how that kind of helps protect the cardiovascular system. It says here, loss of cardiovascular protection, decline in estrogen removes its protective effects on the heart and blood vessels. There are age-related factors. Menopause typically occurs around the same age when other risk factors for heart disease are occurring. So high blood pressure, weight gain, these things become more prevalent. There's a nice little infographic there that you can go through on your own time as well. And then why resistance training is crucial, and resistance training is another thing that we specialize in, right? We're movement specialists. So with resistance training, you're counteracting that muscle loss You're building muscle mass, you're improving overall strength and functionality, you're maintaining bone density, right? So anybody who's been diagnosed with osteopenia, osteoporosis, weight-bearing exercise is the #1 way to increase stimulation of bone growth. Metabolism boost, so as you're resistance training, you're building muscle through resistance training, increasing the resting metabolic rate, helping to manage weight and reduce body fat, you're improving the cardiovascular health, lowering blood pressure, it also enhances mental health, right? What was the, Elwood's, what's that movie?
Legally Blonde.
Which is happy people don't kill people, right here.
Blonde.
Exercise releases endorphins.
I just saw that movie last month.
Okay.
The bend and snap.
Yeah, bend. And don't hurt your back. And then pelvic floor strength, so specific resistance exercises that can target strength of the pelvic floor, reducing.
Bar is great, yeah.
Yes.
We recommend our postpartum women to start here with bar. It's really good.
There's just an additional section of resources, a little bit more specific to menopause. My PFM, mypelvicfloormuscles.com is also really good, a lot of good information there. And then I think we are back to Dr.
And then you'll see, and I'm going to email this to you, but the first one, menopause.org, because I always tell my patients, the patient who delivered your baby is not usually the best healthcare provider that is going to help you through the menopause state, the perimenopausal, okay? So when you go to menopause.org, there's a lot of gynecologists and OBs that have extra training in menopause because there's so much research coming out. And again, research is always 10 years old anyway, so you want to make sure that your doctor's up to date with the latest research. So I usually tell them to go check out that website. And I just want to let you know what is pelvic floor therapy. What we do at Soma Vita Physio is non-traditional PT. I don't know if anybody ever had physical therapy before, but usually you're with the therapist for 15 minutes, and then you're with aides, and no one's really watching you. The way we work is for 1 hour, it's 1-to-1, and you'll always be with either Dr. Lauren or I, and we focus on the individual. So everyone, it was not cookie cutter. Everyone presents differently. We watch how you're moving, watch how you're breathing, and we tailor everything to your specific needs. And we also we are focusing on a lot on injury prevention. So a lot of patients continue with us for a year or 2 years later because they just love working with us and they just feel really great. I had a mom of 4 and she was like, I just want to walk in the park with my kids. And now this is the summer and she's like, I want to run a marathon. She didn't even think that was possible because she couldn't even walk in the park with her kids. So we were helping her get to a 5K. And we're gonna build up, because you can't just, jump right into a marathon. I'm like, let's start with 5K. And as you can see, we have advanced certifications. So we are really dedicated to our profession and really up to the evidence base, knowing the research that's out there. And we are almost at 70 5-star Google reviews. I'm really proud of that. And the way we work is that we have a 3-step process. We're gonna find out what is going on, what is causing your pain, and we're gonna fix those areas. And then we work on retraining you, right? Because a lot of the times, whether you are pregnant, you are adapting to the growing abdomen, or you're postpartum, your body doesn't remember how to move the right way. So we have to retrain your muscles and that brain connection. And then once you get that awareness and you feel confident and independent, that's when we start loading you for optimal performance. So you can feel confident when you're working out, whether it's here at Pure Bar or at home, anything like that. Because spring is coming, might be gardening. That's a lot of work. I'm tired when I garden. So here's just some Google reviews that people left about Dr. Lauren, how awesome she is, and has helped them postpartum and during their